Yeah. So, sir, before we go ahead with the presentations and the discussions, I would just take 2 of the minutes to just introduce what Translumina is all about.
Okay.
So, sir, the Translumina is basically, a company with coronary interventions and incorporated in the year 2000 with 50 plus countries presence. And Translumina is a great place to work with and has been certified subsequently for almost 4 years now. And we have our own five global manufacturing facilities here with us. And R&D excellence is situated at German Heart Center, and with 8 strategic partnerships and 10 years of clinical data of safety and efficacy with CE certified products. So as of now, sir, we have our manufacturing facilities, as I've just mentioned, in Germany and in Dehradun as well. And this is our Asia's first largest laser cutting facility, that is Trans Health, situated at Dehradun. And talking about the 10 years of clinical data of safety and efficacy, that is for Yukon Choice PC and Vivo SR. So recently, there has been an acquisition with Blue Medical Devices that is situated at Netherlands. So the acquisition has given us the access to a patented, innovative, and a proven next generation drug-coated balloon technology, which is basically Protege. So Protege is paclitaxel coronary coated balloon dilatation catheter, which has its global presence in more than 35 countries now, and R&D team and manufacturing facility situated at Netherlands. Protege is EU MDR certified with its patented drug application process, which says that a unique drug application process which has minimal drug loss during transition because of its trifold technology and auto-pipette technology, and further wing seal technology, which has actually ensured there will be effective drug delivery at the lesion site, and there will be minimal to minimal drug loss prior to inflation. And multiple inflations, which means that multiple drug release up to 3 times with the same device. So three times of inflation with the same balloon is possible in the same vessel. And Protege is the world's first only non-compliant balloon that is available with Translumina. So today I would really like to thank you all for joining us. And in the modern drug-coated balloons in the era of modern PCI, which is the, I would say, the basically new technology, new plaque modification device that has been come. And just like to thank you, Dr. CSS Raju Srinivas Raju sir, Chief Consultant in HOD Cardiology Department in KIMS Hospital, Nellore. And so thank you so much for your marking your presence over here, because your expertise really matters to us, and it will be enriching for the basically faculty and as well as our attendees as well who are watching us over here.
Thank you. Thank you for nice.
Thank you. Yeah. So just wanted to take your permission if we can just go ahead with our presentations today.
Yeah. I welcome all the speakers. Today we are going to have a wonderful session on drug-eluting balloon, which is the new area of interest for all the interventional cardiologists, with the concept of leaving nothing behind. So again, no, the clock is turning back towards this thing. So we started with angioplasty in with Andreas Grundig from 1977. September 16th was the first angioplasty performed in the world. From then, the percutaneous coronary interventions have taken a different shapes and then different advances with the technological advances. And then again, we are in some areas where we want to have the newer technologies like the drug-eluting balloon in selected areas, like not only the ISR or the instant restenosis, but also in the small vessels, long diffuse vessels, and then whenever there are bifurcations, and only in the de novo lesions involving the large vessels. So there are so many. We'll have more insight into the topic with all the elegant and esteemed speakers from across the world, across the India, from north to south. So I invite all the speakers, and then without wasting any time, we'll proceed with the presentations.
So, sir, as Dr. Venkata is occupied in the case, so he just asked to continue, and he shall be joining us very soon. So,
Okay.
if Dr. Arvind sir can just initiate with this talk. Dr. Arvind sir, you are on mute.
Yeah, I can start. I can start.
Yes,
Yeah,
yes. Thank you, sir. I'll just stop sharing.
Are you able to see my screen?
Yes, yes.
Am I being audible?
Yeah.
So today I'm going to start I'm going to share one of my case where I've done a drug-coated balloon in an ISR. But this is a platform where I can share what we have done and also gain a lot of information about the practices in drug-coated balloon, different consultants and with their different expertise, we can understand how we can proceed with drug-coated balloon. So here I'm going to talk about best practices for drug-coated balloon angioplasty step-by-step approach. So coronary drug-coated balloon angioplasty is a valuable technique for treating CAD, particularly for ISR and certain de novo lesions. Here it's going to be in step-by-step approach incorporating the best practices that are available. So for drug-coated balloon, the most important thing or the only contraindication when we cannot use a drug-coated balloon is going to be when you don't have a proper lesion preparation. When there is no proper lesion preparation, then there is no point in putting a drug-coated balloon. So that is going to be the most important step for us for doing drug-coated balloon. So we'll have to optimally prepare the lesion with 1:1 balloons so that we can effectively deliver the drug so that there will be very minimal need for us to do any bailouts after that. Okay. So initial dilation, we can use in semi-compliant or an NC balloon with an 1:1 balloon to vessel diameter ratio. In difficult lesions, yes, we can go for, rather than a semi-compliant, we can go for a non-compliant. If needed, we can go for a cutting or scoring balloons, or even rota IVL can be used here. So the common thing is, if we are going to use the higher techniques, say we use a cutting balloon and we end up in a dissection, can we use a drug-coated balloon? Yes, of course, we can use a drug-coated balloon in when there is a dissection which is non-flow limiting, especially a type A or type B dissection, where the late lumen loss at the end of 1 year is going to be considerably better in those patients who have a type A, type B dissection which is non-flow limiting. So using proper preparation of the lesion, using a cutting balloon or an even required and rotor and IVL should not be a contraindication, thinking that we cannot use DEB if you are going to go for an higher balloons. I even see people who don't use 1:1 balloon dilatation, thinking that there will be a dissection and will not be able to use an DCB. I think that should not be a criteria. A proper lesion preparation is very important because it is not only on the day of the procedure, it is the follow-up when we look for lumen loss. This is going to be very important in preparation. So what should be our assessment at the end of lesion preparation is confirming the pre-dilatation balloon is fully inflated and appropriately sized. We should aim for residual stenosis should be less than 30%, especially for the main branches, it should be less than 30%. Ensure that there is an TME3 flow. We should exclude an flow limiting dissection. Type C are higher. If it happens, then we cannot use DCB. We should go for NDES. So for a drug-coated balloon, whatever I said before, optimal lesion preparation, balloon to vessel ratio is 1:1. Use whatever modality needs to be done, use it. And when you get an acceptable result with the POBA, and even if we say we want to use imaging, there is data emerging that in comparing with IVUS and non-IVUS, using imaging and non-imaging, the data was far better results were achieved when you used a drug to IVUS imaging to do an 1:1 balloon dilatation and then do DCBs. So this is the time. After the lesion preparation, we can use imaging, and I don't think we should be using the DCB should be the last hardware that we use when we use for the DCB should be the last hardware in your procedure. So and the DCB to vessel ratio should be 1:1, rapid delivery, nominal pressure, and go for 60 seconds of inflation. So what is the result assessment after lesion preparation? It is crucial to decide whether to proceed with DCB or opt for stenting. Indication for stenting is when after proper preparation, if we have a significant recoil, that is more than 30% residual stenosis is there, you should go for a stenting. If there is a flow limiting dissection, that is type C or higher, if you have a staining, type C is nothing but you have a dissection, but the dye stains there. or if there is an TME2 flow that you're getting or any signs of ischemia, you see, we can do it. We can even use FFR to do a pre-FFR and post-FFR, pre and post-POBA, and the cutoff is 0.80, but a lot of people with a lot of literature, we can take 0.75 as a comfortable cutoff. More than 0.75, we can still go ahead with DCB. So DCB angioplasty, primary for drug delivery, not for further lesion dilatation. So sometimes we see a type A lesion, and we want to put for the shortage of time, if you want to put directly in DCB, those are the times we see most of DCB failures happening. That too, early in the learning curve, people would want to think, oh, this is going to get dilated with just with the DCB. We're going to inflate for 60 seconds, which shouldn't be taken for granted. Always in proper SC balloon dilatation, step by step goes SC. If not, then go ANC. If not, then go for higher balloons, as we do for stenting case. So procedure DCB handle the DCB very carefully. Avoid contacting with the balloon surface to prevent drug loss. Position the DCB to cover the entire pre-dilated segment, and always better extend 2 to 3 centimeter beyond on each side to miss and geographical miss. The DCB diameter should be should match the target vessel diameter. Inflate the DCB to nominal pressure only. Don't go higher. The same thing that can happen with our NC balloons, we can extend the dissections, or when the balloon ruptures, we can dissect the vessel. So always try to stop it at nominal pressure. And the drug delivery time, ideally we should follow the manufacturer's recommendations, and we should go for 60 seconds of drug delivery time. So aim for an expedited delivery to deletion. So the tracking should not take more time for us to go reach there. We should go as quick as possible. Say we are going to use something like, you think it is going to be a difficult crossover, we want a guide extension or something, all those things should be prepared. Only then the DCB should be taken to our target area. And avoid post dilatation. Once DCB is done and you think we have not prepared well, let me go dilate again, all those things should be avoided. So post DCB result assessment, check for complications, look for flow limiting dissections. Either if there is a recoil, more than 30% recoil, that is an inadequate result. If you have got a type C dissection or more, it's an inadequate result. If there is the flow is reduced, it has gone to a TME2 flow, then it is also not a good result. So how do we manage complications? Type A, type B dissections are often non-flow limiting and may not require intervention. I would say those are all the good results. Achieving an stent-like result is not the great result. A result with type A, type B dissection and then using post-DCB, those cases when we follow up over a period of time is when where we'll have actually very good results with lesser lumen loss. So bailout stenting, if significant recoil or flow limiting dissections occurs after DCB angioplasty, bailout stenting with a DES may be necessary. Non-flow limiting dissections, close observation and follow-up. So ideally what I do in my practice is, in this type A, type B dissections, I wait, I keep my wire inside, I don't lose my access. I give and wait for 5 to 10 minutes, or if I'm working with an, say I'm doing an OM and I have an LAD work to be done, I finish the OM work, I leave the wire there, I just go finish my LAD work and then come back and check, see if all is okay, if it is still not flow limiting. And it does usually worked out for me well, and in follow-ups also the patients are doing good. Specific scenarios in bifurcation lesions. DCB can be used for side branch angioplasty, often in conjunction with the main vessel stenting. Scoring or cutting balloons are often preferred for ostial side branch lesions. For diffuse lesions and hybrid strategy, that is proximal you want to stent and distal you want to do DCB angioplasty, it might be considered, especially in our practice scenario. All those diabetic patients who have diffuse diseases, we don't have to metal jacket the entire vessel. Now we can use in long DCBs down, and we can with imaging find a good target landing zone, and we can do shorter stents. And even in CTOs, the hybrid strategies can be followed. Say for example, in the CTO segment alone, we can put a stent, and if there is a diffuse disease downwards, we can use a drug-coated balloon. So DCB treatments approach for true bifurcation lesions. So optimal preparation for the main branch and side branch, 0.9 to 1 is what we'll need to do. And for main vessel, I said non-flow limiting and residual stenosis less than 30%. This is where it gets better. In side branch, we don't need that much amount of thing. Even more than 50 or 60% is actually acceptable in a side branch. And yes, if you're getting any flow limiting, say we get acceptable in main branch and side branch, 1-on-1, we can do DCB on main vessel and DCB on side branch. If one is yes and two is no, DCB on main branch and provisionally for side branch. If you've got non-acceptable in main vessel, then you can go for a DES here and DCB, and that is the combination we can play. So almost and everywhere what it goes is we don't need to do true bifurcation stents. We can actually go for main vessel with a stent, and we can go for a side vessel with an DCB. What I usually do is I sit in the end. I use my DCB in the as the last thing. I take my main vessel with an NC balloon for kissing, and I take a DEB on the other side, kiss it and come out. So DCB treatment approach for CTO, the hybrid strategy would work better, and spot stenting only for the CTO segment, and where the distal segment we can go for an DCB. Even in acute MIs, I see a lot of Western people posting their cases up showing that we have done DCB in acute MIs. So far, I have not done. Maybe I've done in NSTEMI patients or in people who have elderly patients who have got high bleeding risk. I've recently done it for one posterior wall MI patient with circumflex totally 100% occluded, didn't DCB on follow-up. But I don't have any data where I can say confidently say 6 months, 1 month, 1 year later, the patient is fine. But I've started using it for elderly people, geriatric people who are high bleeding risk people, explain them clearly, and I've done DCB for those patients. Important notes: intravascular imaging, while not routinely used post DCB, it can be valuable in assessing plaque and calcium burden in complex lesions for evaluating lumen gain in specific situations like ISR. DAPT, the recommended DAPT after DCB treatment can vary on whether the stenting was also performed, typically at least 6 to 12 months in case of DCB plus stenting. In patients only with only DCB, what I do is I put dual antiplatelets for 1 month. Post that, I switch them back to single antiplatelets. So this is one of the cases, a recent case that I've done. It's a 70-year-old male at ER, ACS. He is in diabetic, hypertensive, mild LV. The thing is, he had 2023, he had an massive MI. He was intubated 7 days. He was in the hospital. He had a metal jacket at RCA done by another person. He had put in distal stent of 48, 2.75, 48, and proximal 328. Patient did well. Then the patient also had a disease from LMLAD, and he went to an elsewhere hospital where he was stented LMLAD. And now coming back, today's last month scenario, he came here, and the LMLAD stent was patent, and we found an ISR in type 1D ISR in mid part and type 3 ISR in the distal part. So what the plan was, let's go do DCB to RCA. So this is the angiogram. So in fact, L6 was a non-dominant one compared to what it was there in the 2 years back. The L6 has actually grown up here now with a TIMI1 flow. The LMLAD done stent is patent. So this is the RCA angiogram. So you will see he has a type 1D ISR in mid RCA and type 3 ISR in distal RCA. The stent was stopped at the crux. The lesion is extending inside the PDA right now. So RCA was wired, the lesion was pre-dilated within, so 2.75, 48 was the distal stent that was put. So what we did is what I did was I pre-dilated right from PDA across the distal segment of the stent. If you see that the image that has been shared in front of you, and also dilated the upper part with 3.5 balloon, NC balloon. So post NC balloon only, there was a good amount of result. There was a good result. There was a good dilatation that I was able to see. So used in 2.2520 protege for the distal RCA across to the PDA. And used in 320 for mid RCA and 330 protege for the proximal RCA. So post NC and DCB to mid and proximal RCA, TIMI3 flow is achieved. Thank you.
That's wonderful presentation from Arvind Durvasal. I think we will have questions at the end of all presentations. That would be fine, so that
Yes,
all the
yes.
panelists would join, and then we'll have whatever questions either in the chat box or directly from the participants. We can have interaction.
Sure, sir.
We will very nice presentation, Arvind. You made crystal clear all the points to be remembered while doing DEB, and then the most important, you have emphasized all the important steps.
Thank you, sir.
I would like to invite Dr. Rupesh Singhal, sir, our consultant interventional cardiologist from Shalvi Hospital, Ahmedabad. Sir, can we have your presentation, please?
Yeah, thank you. Thanks, Transformator, for organizing this. Let someone else is sharing. He'll need to close first. Dr. Arvind, please. Stop sharing, please. Okay. 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 So my slides are visible. So
Yeah.
Dr. Arvind did a very good, I mean, it was a very impressive presentation. He covered a lot of aspects. So my topic is patient selection. So DCB, who should get them? To know that, like, we have been doing stents in and out for quite a long time, and we all know why stents fail. So despite all our best efforts with the contemporary DES, with the good generation, the fourth generation DES, there is still a 2% lesion, on an average 2% lesion failure rate that is seen, despite all the therapies, all the optimizations that we do. And DCBs have been introduced, like it's like a life coming full circle. So DCBs, as pointed out, they are a drug delivery mechanism without leaving a permanent implantation, and they serve as an alternative to DES, particularly in where you have this area where, like, you might say the DES might be unsuitable. So this concept is leaving nothing behind is gaining popularity. Reason we are able to deliver the drugs properly with this therapy, which is now a lot of evidence has come, which I will share. And we are getting better and better at accepting which dissections to accept, which dissections to treat. With the advent of imaging, our angioplasty has become more precise. So the rates of acute vessel closures have actually gone down, and hence we can just do a DC pen pull off. So traditionally, as of now, the approved indication for the drug coated balloon is ISR. A lot of studies are going on, and real world usage has extended into small vessel disease, tortuous vessels, high bleeding risk patients, bifurcation lesions, and selected ACS patients. So I'll just go through these cases on one by one, and let's see how we have how DCBs perform in all these segments. So as very nicely pointed out, it comes down to optimal lesion preparation. And what needs to be borne in mind is DCB is just a method of drug delivery. It is not there for lesion preparation. We need to ensure that lesion preparation occurs before we are doing the final coating with the drug. So in-stent restenosis, the oldest known nemesis of stents, and we have seen an era of BMS restenosis. We have seen an era of DC drug DES restenosis. A lot of data has come with the use of DCBs in BMS and DES restenosis. In this table, I summarize the data of the DCBs in BMS restenosis, and what this data essentially summarized that DCBs were non-inferior to DES in treatment of BMS restenosis. DES restenosis is a different ball game. Initially in the trials like PEPCAT DES, which were and RIBS4, which were relatively older study, DCB were just keeping up DES, but with the more recent ISAR desire, DCB and DES did similar in terms of DES ISR treatment. So in the most recent DLDES study, this chart is from the DLDES study, which was published way back in 23. And what they did is they did a 2x2 design of treating the BMS and DES ISR. It was a like an analysis which they did. And what they said is, in patients with less aggressive pattern of ISR, like focal and good lumen expansion with balloon dilation, DCB is favored. In BMS ISR, definitely DCB is favored. In multi-layers of, like when there are multiple layers of stent, again a DCB is favored. In patients who have high bleeding risk, again DCB is favored. And where there is like a side branch, which is there, which there is a significant risk of jailing on treatment with a DES, again a DCB is favored. So this is one particular patient stented at an outside hospital, two long stents ranging almost from the proximal most part of the LAD till the distal LAD, 248 millimeter stents, multiple levels of ISRs, treated, dilated with a cutting balloon and a NC balloon. This is the final result after the DCB. The patient almost done a year back now. Same, like, so ISR is now an established indication of where we use a DCB, but let's explore furthermore areas which may not have an official FDA clearance as of yet, but are very promising and where we use them. So we know that size matters. We know that small vessel have highest restenosis rate. There are stent delivery challenges, higher thrombosis risk, and there is a limited efficacy of drug-eluting stents in very small vessels. And we, as our experience, from our experience, we know they have a very high need of, again, target lesion revascularization. So this is a basic summary of the various studies and how small DES, as defined around 2.5 and 2.75 in some studies, behave, and we see that the restenosis rate and TLR rates are really, really high. So DCBs in small vessel disease, again, a lot of data is already there, and we see that DCBs are actually in the contemporary Piccolo 2 study are doing better than DES in patients of less than 2.75 millimeters vessels. So this is again a tight RI restenosis patient presented with troponin positive, just dilated with an NC balloon. In fact, I did a cutting balloon. So my go-to strategy is, if I'm planning a DCB, I tend to use a lot of cutting balloon, and I do believe in the concept of cut and paste, cut and coat. And so this was initially, there was dilated with a routine balloon, then a cutting balloon, a final DCB done, and this is the final result. Size matters, but so does length. So patients having diffuse disease again have much higher rates of restenosis, thrombosis, and lesion failure rates. Even with the contemporary stents in most the newer generation stents, still if you compare the DES data in long lengths versus short length, you see the restenosis rates and TLR rates are almost doubled compared to when used for less than when used for smaller lengths. So again, when compared DCB versus stents in long lesions, DCB remained non-inferior and did equally well, at the same time limiting the implant lengths. Metal jackets, as rightly pointed out, I mean, in cases where there is no optimal landing zones, you cannot really identify, and if you keep stenting and chase every dissection, you'll end up with a metal jacket, like this gentleman who ended up with 34 stents. So this again is a case. So this is an like an elderly, very obese, heavily diabetic patient who presented to us with significant angina. She was already on all the medical management possible, and this is her coronary angiogram. No, as you can rightly see, no optimal landing zones, very small diffuse disease, diabetic, long lesions, and in fact a bifurcation disease with a small branches, both LAD and diagonal. So a very heavily calcific lesion, it was not yielding. We did a cutting balloon and we did a high pressure NC and ended up with a flap which was not looking acceptable to me at that point. So I stented that particular LAD, but then did a side branch DCB for the diagonal, for the LCX, and for the major OM branch. And this is the final result. You can see there is some dissection in the diagonal, some small element of dissection in the OM also. But again, this was non-flow limiting. This has been done almost 1.5 years back, and still the patient is doing well. So again, this concept of vasomotion is very important. If you artificially sort of bend the contours of the vessel by putting in a metallic implants, you sort of limit the vasomotions. As pointed out, vasomotion is very important for the endothelial well-being, and this has been proven in a number of bench studies and where the basic sciences studies, where endothelial dysfunction and higher stenosis were noted when vasomotion was limited. So again, this has translated into clinical outcomes, and we see that target lesion failure is much higher in patients with tortuous vessels. So this is a case from, in fact, today morning only. So that is why the video rather than the from the diagram. So this is an RCA, almost after 360-degree bends, diabetic patient. So this is a DCB only approach. I did a protage for the distal and the mid RCA. We can see some flaps again in the PD and a small flap in the mid RC also, but they were non-flow limiting. And now, as I've used a lot of DCBs, my confidence of accepting a certain amount of dissections has actually increased. So this is the result that we did today. Any stent that I would have put in, even if one, it would have been very difficult to track, and there was a bifurcation there. It was a tortuous vessel, and it would have caused more problem than good. So in patients of high bleeding risk, patients requiring major surgeries, like patients who have come in for oncology surgery, again, DCB only approach is gaining a lot of momentum and has shown promising results, where the results have been much better. So bifurcation PCI, again, bifurcation PCI has been fraught by suboptimal results for ages. We have now enough data to support that provisional strategy is way to the go. And again, when we accept that provisional strategy is the go-to strategy, why not just do a DCB and coat that side branch with the drug? In fact, the biggest complaint that I have with DCB is, like, after the advent of DCBs, my two stent bifurcation PCIs have gone down. So that's something that I used to enjoy. But DCBs do much good and give very good clinical outcomes, and hence the reason why the bifurcation, dedicated two stent bifurcations, are going down now. So a lot of studies have looked into this: Babylon, Depside, Hyper, Biolux. A lot of studies are evaluating whether DCB only approach for both the main vessel, a hybrid approach where there is a DES in the main vessel and DCB in the side vessel. There are studies, in fact, looking where you pre-dilate the side branch with DCB, and or versus as you do the DCB as the last step in the casing PCI. So a lot of data is going into this, and most of this data that is coming out is favoring DCB specifically for the side branch. So this is actually an ACS patient that presented with anterolateral wall MI. After much difficulty, we actually, if you can see, there is a very faint diagonal that is filling in, which was totally occluded. So this was dilated. Again, there is some disease in the main LED. We wired it, but did nothing to it. This was like a 275 protease, 30 millimeters. And this is the final result. Again, there is dissection in the side branch, which we were very confident in accepting. This was a 78-year patient, and this has been more than 6 months now. So our experience with DCB has been very good, and ultimately it boils down to, like, why do DES fail? How often will the patients come back for revascularization after a DES? What if there is some stent thrombosis? What if the patient needs to stop the drug, DAPT drugs? So what to do? And ultimately, DCBs are providing an answer to this question, provided we use DCBs appropriately. The idea is to select the proper patient, have very optimal lesion preparation, assess whether you have done a good job at lesion preparation, and then do a DCB. So this is a slide which I would like to repeat. It comes down, please prepare your lesions properly, please pre-dilate properly, use cutting balloons, rota, IVL, whatever be needed, and then use a DCB to deliver the drug. So again, this is not saying that DES is out, but yes, and a synergy between DES and DEB will give you the best results. Thank you.
Thank you, Dr. Rupesh. That is again an excellent presentation. As he has concluded that the DES and DEB are going to be complementary rather than competitive ones, and you select the patients properly, prepare the lesions properly, and then judiciously use, and let us not worry too much about the dissections, which earlier every dissection doesn't require a DES to cover it up, and the dissections are an initiating process for healing by remodeling. So they leave them, allow the vessel to dilate and heal it by itself. And because there is a drug coating there, it's not going to really cause any acute recoil, or then no more fears about leaving them alone. And then they heal by themselves and result in a what you call leaving nothing behind, and then no metal. And subsequently, if there is anything, you are leaving a area for the surgeon to operate also. So thank you very much, and then we will move on to the next talk, and then we'll have a discussion at the end. Any queries on the chat box? Anyhow, we will take up at the end. All the panelists, all the speakers would be participating in the discussion at the end.
Okay. Dr. Ajwa sir, can we have your presentation, please?
Yes.
So, yeah. Sir is from VPS Lakeshore Hospital, Ernakulam.
Good evening, sir. Good evening, everybody. Today we'll have a small discussion on what the role of DCBs in side branches and small vessels. So coming to how small is a small vessel? So there is still a lot of controversy regarding that, because almost 50% of the angiogram we see, and of which 50% are of the coronaries involved are small vessels. And of that,
Dr. Ajay, can we have can you switch over to presentation mode?
So the slideshow, basically, there is an option at the end, right hand.
Yeah, is it now correct?
Not yet.
Not yet, sir.
Just a second.
Just at the side of the 100%, screen.
Yeah, I think.
Where you can minimize and maximize.
Just a second, I'll just open it.
Sure.
Yeah.
Yeah, it's visible, sir, now.
Okay.
Thank you, sir.
Okay, so can we start this? So yeah, so coming to how small is a small vessel. So we see that almost 50% of the angio we see are usually involving the small coronaries. That is size that we'll be coming to later. But involved of that, the 50% of them will require interventions also. And the phenotype mainly that involves the small vessels are usually a female sex, old age, patient diabetes, and those having peripheral arterial disease and long lesion length. And the definition is inconsistent. Actually, there has no definite cutoff value to say which is exactly small vessel. And to see that, to classify them, they have the different trials use different millimeters. For example, the ICER trial use a vessel less than 2.8 millimeters, and for the very small coronary artery disease, they use a reference vessel diameter of between 2 to 2.25 millimeters. So now, what are the importance of this small vessel is small vessel coronary disease? But see, to know the proper estimation of the prognostic impact of this obstructive coronaries involving the small vessel, it's very difficult to conclude. Mainly because of the standardized definition that we have just came to know that. Then also of the 30% of the patients with lesions in the proximal coronary disease, they also have a concomitant lesion involving the distal arteries. Whereas those involving the distal arteries definitely will have a proximal coronary artery, proximal or large vessel involvement. So we won't be able to exactly come to a conclusion regarding the clinical implications of this or the prognostic implications of a small vessel disease. And also the clinical importance of the small vessel also depends upon the diameter and also depends upon the length and also the diameter of the vessels. And finally, what we see in the coronary angiogram may not be the exact true vessel diameter, because in case of ACS or NSTEMI, they usually go into a spasm, and most of the time it is often underestimated. So the current therapeutic strategies in patients with small vessel coronary disease are mainly the conventional FOBA, that is the plain old balloon angioplasty, or the bare metal stents or the drug-eluting stents, and now we have the drug-coated balloon into our armamentarium. So the initial or the traditional drug that was used is the paclitaxel. Now we have the sirolimus eluting drugs also. So what is the difference between the two? The paclitaxel coated drug coated balloon and the sirolimus coated. So this paclitaxel is basically a highly lipophilic and cytotoxic drug, and it is in the initial time of DCB, and also the carriers used are basically urea, BTSC, shellac, etc. And the coating is done with the hydrophilic spacer. The mechanism of drug delivery is by Van der Waals force of attraction, and the tissue take-up is variable. And whereas the sirolimus coated drug-eluting balloon, they are less lipophilic, cytostatic, and the carrier uses phospholipid. The mechanism of drug delivery in this in sirolimus DEB is mainly by fixed lobe diffusion, and they use the nanolute technology where they predominantly use a type of DCB which is characteristic called submicron carriers. That means this drug is mainly coated by a phospholipid encapsulation that is used for drug delivery. Now coming to the trials where we use small vessel disease are being was tested, and the first trial to study the use of a drug-coated balloon in small vessel disease was the PEPCAD-1 trial, where 118 patients with single vessel with small vessel disease was used for the study, and the vessel diameter for that was 2.36 millimeters, using the sequent phase balloon, sequent please balloon. And it was seen that approximately 30% of the patients required bailout BMS, stenting, and 18% had ISR at follow-up. And the first randomized study to try to compare drug-coated balloons to stenting to the drug-eluting stent was a Picoletta trial, and that included vessels with a reference vessel diameter of less than 2.75. But the trial was stopped prematurely due to the superiority in the DES arm. But the limitations of this, why this happened, mainly was attributed to a few reasons. Mainly because they used the first generation drug-eluting balloons in the first case, and the lesion preparations were not adequate in the drug-coated balloon arm because it was initial studies. And the rate of bailout in the bare metal stenting was high in almost 34%, and many of them were bifurcation lesions, including 22% of the cases. And in 2012, the Bello trial randomized 182 patients with a small vessel disease of a mean diameter of 2.15 to the impact Falcon DCB versus the Taxus DES. The study demonstrated almost comparable clinical outcomes at 6 months and up to 3 years follow-up. And various observational studies were also dealt with, and they showed that the DCBs were comparable to second generation drug-eluting stents in small vessel disease, even in vessels diameter with a diameter of 2 millimeters. The randomized the basket small 3 trial was the first and the largest trial to compare the use of DCBs and the second generation drugs. We'll see how and followed by the restore a small vessel disease trial. The restore this trial showed that 9 months follow up, the restore DCB was non-inferior to the resolute DES for in segment percent diameter stenosis in 230 patients. And a recently published meta-analysis of 1,824 patients demonstrated that DCBs had better outcomes than uncoated balloon angioplasties, and comparable angiographic and clinical outcomes with DES in small vessel disease during a mean follow-up almost 1 year. So these are the trials that evaluated the role of DCBs in small vessel coronary artery disease, and all of them had a better outcome, and almost that means equal outcome compared with the drug-eluting stents. And the Piccoletto trial, Bello trial, the basket small 2 trial. So all of them were equally, all of them trials showed that they had similar outcomes in small vessel disease, but except for the which in the Piccoletto trial, where the trial was prematurely discontinued because of the high failure rate. And then came then this considering all this, the basket 2, Piccoletto 2, the restore SVD and the Bello trial, it was seen that on long-term follow-up, that is 3-year outcome, the major adverse cardiovascular events, the all-cause death, the myocardial infarction, the target lesion revascularization, and the target vessel thrombosis all favored the drug-coated balloon for small vessel disease than the drug-eluting stent. So coming to the bifurcation strategy, the Potsdam registry, which mainly focus on leaving nothing behind, almost 13 interventions were taken into study, and the procedure was successful in all patients. And here it was seen that no MACE, or that is cardiac death or myocardial infarction, target lesion revascularization occurred up to 30 days in bifurcation lesions, including drug-coated balloon. And the duration of DAPT was approximately 4 months. So these are a few steps. Here we now we can initially in bifurcation lesions with the Medina of Medina of 111. Here we can the side branch stent can be initially pre-dilated with a drug-coated balloon. After proper lesion preparation, then a DCB can be inflated by 1:1 or 0.8:1 balloon to vessel ratio. The most important thing is adequate position time has to be given, be it the small vessel or be the side branch. And it is now said that controlled dissections are even very much useful for better results, because they actually help in better drug penetration and a proper long-term outcome in by inducing controlled dissection. So the use of a cutting balloon or a scoring balloon prior to the procedure may even in fact be helpful in patients when we are going for a drug-coated balloon, unless otherwise the TIMI flow is less than 2. So then we can decide whether to go with the bailout stenting or whether to continue with the drug-eluting stent. So and also in patients where we are doubtful, because there is a size mismatch between, for example, if a large RCA divides into, like, extending into a small RPD and RPLB, and the lesion is in the ostium of the RPDA, which is where we have to stent into the main branch, then we can go for a drug-eluting balloon, and better results have been seen. So summarizing what we are seeing in patients with small vessels, in patients with small vessels, the Andromeda study, the outcome or the efficacy at the end of 3 years is equal for drug-coated balloon and drug-eluting stent. And even the composite of all-cause death, myocardial infarction, target lesion revascularization, or target lesion thrombosis at the end of 3 years, that is, safety outcomes even were better with the drug-coated balloons when compared to drug-eluting stent. Now, it's a small case of it's a straightforward case of two vessel disease involving both LAD and major OM. The LAD was dealt with, and PCI with the drug-eluting stent was done for the LAD, following which 2 by 30 millimeter protege was done, and inflated for around 90 seconds, and a decent result was obtained. And in such cases, we can easily see the length. Though it's a small vessel, the length of the vessel is quite large. So in such cases, score better with a drug-eluting balloon than a drug-eluting stent or a plain old balloon angioplasty. Thank you.
Ajay, that is again a very nice presentation, and then you have pointed out rightly all the major points to be emphasized. And then we will move on to the other speaker. I think the last speaker.
Yeah.
If Sivakrishna is not available, then we'll have discussion at the end.
So I would like to request Dr. Anil Sharma, sir, from IVY Hospital, Senior Interventional Cardiologist, Amritsar. Sir, can we please have your presentation?
Meanwhile, I request the other participants, if you have any special queries, please put them in the chat box, or you can directly introduce yourself and raise the questions.
Thank you, Garima. I'm audible?
Yes, sir.
Sir. Good evening, sir. Good evening, dear friends and colleagues. I'm Dr. Anil Sharma. I am a consultant in Levasa Hospital, Amritsar. Today, I'm going to talk about how paclitaxel works in coronary DCBs and its local anti-proliferative effects. So paclitaxel, everybody knows that it's a cytotoxic agent and it's derived from Pacific yeast tree, and it's classified as a microtubule stabilizing drug. It inhibits cell division by binding to and stabilizing beta tubulin, preventing microtubule depolymerization. Paclitaxel coated balloons, PCBs, are used in PCI to deliver anti-proliferative drugs without leaving a permanent implant. And PCBs deliver paclitaxel directly to the vessel wall during balloon inflation. And paclitaxel is the most commonly used drug in coronary DCBs due to its lipophilicity and sustained tissue retention. Tissue concentration and retention. It achieves therapeutic concentration within seconds of contact, and it is retained in the tissue for up to 30 to 60 days, which is sufficient to inhibit the restenosis, and it requires very minimal microgram level doses. Mechanism of action of paclitaxel and its anti-proliferative effects. It is depicted in this diagram. Basically, it acts on microtubules and it arrests the G2 and M phase of the cell cycle. Microtubule stabilization. Paclitaxel binds to the beta subunit of tubulin within microtubules. Unlike other antimitotic drugs that inhibits microtubule formation, paclitaxel stabilizes microtubules and preventing their depolymerization. This basically freezes the microtubule dynamics, which are essential for the mitosis. As a result, vascular smooth muscle cells are arrested in the G2 and M phase of the cell cycle. Inhibition of vascular smooth muscle cell proliferation. After angioplasty, everybody knows that injury to the vessel endothelium triggers vascular smooth muscle cell proliferation and migration into the intima, which ultimately leads to neointimal hyperplasia. Paclitaxel suppresses this response by inhibiting DNA synthesis and mitotic spindle formation. It prevents restoration of cell cycle, leading to apoptosis or prolonged cell cycle arrest of the proliferative cells. Now, coming to the prevention of neointimal hyperplasia, paclitaxel's anti-proliferative activity reduces the thickening of the vessel wall. Neointimal hyperplasia is the key mechanism in the restenosis after angioplasty or stenting. By suppressing smooth muscle cell response locally, paclitaxel maintains luminal patency. It has anti-inflammatory effects also. Paclitaxel may also modulate pro-inflammatory cytokine release, which is TNF-alpha and interleukin-6. It reduces leukocyte infiltration at the injury site. These anti-inflammatory effects create a favorable healing environment and reduce vessel remodeling. Now, coming to the effect on the extracellular matrix modulation, it inhibits secretion of extracellular matrix proteins by vascular smooth muscle cells, and it reduces matrix deposition, which is involved in the plaque progression and restenosis. Now, coming to the mechanism of late lumen enlargement, it involves basically the growth of the entire vessel and the regression of plaque volume. Various serial IVUS studies have shown that increase in external elastic membrane and lumen volumes showed a reduction in plaque volume, and 74% of the lesion demonstrated late lumen enlargement. Predictor of this LLE was the dissection index, which was the strongest predictor. And the hypothesis behind this is vessel dissection may facilitate paclitaxel diffusion into the vessel adventitia and triggering late lumen enlargement. As far as the clinical evidence of LLE is concerned, LLE occurs more frequently detected in de novo lesions than in ISR lesions, and serial angiographic follow-up of 250 de novo lesions at 6 months and 1 year, and more than 1 year after DCB treatment. The results were early lumen enlargement observed in 50% of the lesions, whereas about half of the lesions without early lumen enlargement eventually developed late lumen enlargement, suggesting a biphasic pattern of lumen enlargement. Evidence from various RCTs, a systematic review and meta-analysis compared limus-coated DCBs with paclitaxel-coated DCBs across 6 randomized controlled trials, and primary outcome There was no significant difference between the limbus and paclitaxel drug-coated balloons at mean of 13.4 months follow-up. As far as the secondary clinical outcomes are concerned, there was no significant difference between the two groups. Whereas as far as the angiographic outcomes are concerned, paclitaxel performed better, and paclitaxel DCBs had smaller late lumen loss, better minimal lumen diameter, and lower rates of binary restenosis, high rates of late lumen enlargement. Now coming to the evidence from the RCTs, major novel finding was paclitaxel DCB showed 50% incidence of late lumen enlargement versus 27.5 with limbus DCBs. Late lumen enlargement is linked with favorable long-term angiographic outcomes and comparable results to DS in selected lesions. Mechanism of late lumen enlargement with paclitaxel is superior lipophilicity, rapid tissue absorption, and retention in the plaque aided by healing of minor dissections. No evidence that paclitaxel DCBs increase mortality compared to the limbus DCBs. Overall, paclitaxel DCBs demonstrated angiographic superiority, while clinical outcomes were equivalent with other two DCB types. Now, concluding, the presence of paclitaxel deposit on the vessel surface driving diffusion into the arterial tissue in a time-dependent fashion, and it supports the mechanism of action of PCBs. Paclitaxel in DCBs deliver rapid, localized, durable, anti-proliferative action. It works by halting the vascular smooth muscle cell response to vascular injury, the primary cause of restenosis. Its pharmacological and physiochemical properties make it uniquely suited for balloon-based delivery where no stent is required. Now, coming to one of my case, which I have performed a few months back, my patient was 64 years old male, and he had end STEMI. He had previously anterior wall MI, underwent PTCA with DES to LAD and LCX in 2016. I did angio, and angio was showing two vessel disease, LAD and LCX ISR, which was type 4. He was hypertensive and had mild LV dysfunction. This is the angiogram. There was a CTO of LAD, and there is almost near total occlusion of L6 also. This is another view. So a strategy was to treat both the lesions with the DCBs. So CTO was LAD CTO was crossed with the help of some balloons and other hardwares, and ultimately a flow was established. We did an OCT. And OCT showed within the lumen there was a fibrous plaque and neointimal hyperplasia, along with the proximally some calcified and thrombus. We did adequate preparation of lesion, and after adequate preparation, we assessed it with the OCT. And once we were satisfied with the diameters, then we applied DCB protege at different locations with the 3 different inflations. And then we planned for intervention of LCX. LCX OCT was done. It showed again a mixed plaque and some calcification at the proximal end of the stent. And we tried to prepare the lesion, and with the cutting balloon, this non-compliant balloon at high pressures. But ultimately, we can't be able to dilate properly, and we didn't get acceptable diameters of the proximal lesion, proximal to the stent. So we have to go with the stent. And even inside the stent, there were some areas which were not well expanded. So we decided to put a stent across the stent length and covering the proximal lesion. And finally, an OCT was taken, and we accepted the acceptable diameters, and final results were very nice. So highlights of in the case, basically we planned straight at the planning mode. We thought that we will be putting 2 DCBs in both the vessels. PCB protege was used to cover the entire length because lesion length was larger. So we have to use it at different places with the same balloon. So we chose protege, and LAD CT was treated nicely. Whereas we have to change our strategy from DEB to DES because of failure to achieve the acceptable lumen in the LCX. Thank you.
Thank you, Dr. Anil Sharma. I think that is again a wonderful presentation. Now we will start discussion about a few points. I'll just keep the ball rolling. My initial question is, so you have taken a one balloon and then as it was thought, then dilated at 3 places with say inflation of maybe 30 to 60 seconds at
Yes,
each
sir.
site.
Yes.
So, how efficacious will be the third inflation in the same vessel when compared to the first? And how is the drug distribution released at the three different sites? And will there be any difference in the what you call the recoil rate or the restenosis from the first inflation to the third inflation at the end of maybe 1 year or 2 years?
Sir, as far as the protege is concerned, if I'm not wrong, first inflation, it gives around that drug is delivered to the vessel wall around 20 times than the therapeutic level. And the second inflation after 30 seconds, when you put it at the different lesion site, it is around, I think, 12%. And the last one is 8%. 8 times.
Okay, 8 times. Okay. Anybody from Translumina can highlight the importance of taking a single balloon and managing a long lesion with 3 times dilating in different parts of the vessel, and how efficacious it's going to be in the long run.
Basically, sir, if we talk about Protege has its unique drug coating application process from application process to basically the multiple inflations. So the balloon has trifolds, and within the folds of the balloon, paclitaxel has been coated in such a way that it has been tightly wrapped. And once the wrapping and the application process has been taken place, further the balloon has been crimped. So once it has been crimped, the corrugation has created over the surface of the balloon, which actually makes the balloon low profile, and there is no frictional abrasion. So it actually makes the balloon a good, better for crossability, trackability, and the balloon has become flexible further. And then once it is done, sir, because of its wrapping technology, and there will be minimal to minimal drug loss due to PVP also, because PVP is polyvinyl pyridine, so it has its own property of holding the drug. So upon inflation only the drug will be released. So on first inflation, the 65% of the drug gets released. On the second inflation, let's say, sir, if the lesion length is 54 mm, just say, and we have a maximum length of 30 mm. So in first inflation, basically the first 30 mm of the length can be catered with in first inflation. What we say 30 seconds would be enough, but again, sir, it is up to every expertise, basically experience, and what they actually facing with the patient in actual. So on the second inflation, then again 25% of the drug gets released, and in the third inflation 15%. And even at 15%, so it is still above the therapeutic dose of paclitaxel, which is 1 microgram mole per liter.
Just a small question. What about the blood? What about the loss that we'll have in the stream while taking it from the from outside
One part.
the patient side? So you said and math of 100% worked out for 3 dilatation. So what about the loss that we are going to have before inflating the balloon?
So, sir, basically it has been designed in such a way that there will be minimal to minimal drug loss. Actually, it has no drug loss, but still, to accept the truth, it has no drug loss, sir, as per its technology that has been manufactured in.
Okay. So that means to say that we
That
can
is the
take
reason, sir. Yeah,
we
so
can
that is
take
the reason we are
enough
saying.
time. The regular time of other DCBs where we say we have to deploy it within 2 minutes. So
2 minutes, yeah.
that does not go well with Protege. I can take good 5 to 15 minutes before deploying it.
Yes,
No,
sir.
the time of reaching the vascular site is 2 minutes. But the question is, when you start inflating, at each time you are inflating, say, 60 seconds. So the whole time is going to be, suppose you give 3 inflations for the same balloon. You have taken 2 minutes or 1.5 minutes in reaching the site. And again, you are taking 2 to 3 minutes. The whole process lasts around 4 to 5 minutes.
4 to 5 minutes.
What is his question is whether for the last inflation, does it hold good that you have crossed 2 minutes of drug delivery? Still, is it efficacious, or it is doing the same job as first inflation?
Yes. Ehsan sir, yes, you're raising your hand, sir.
Yeah. I was just trying to actually get immersed into the great discussions which we was having. Sir, actually answering to Dr. Anil Sharma's question, I think already there has been addition from Dr. Raju. Thank you, sir, for doing this. In fact, sir, what we are trying to provide the message point home is key. In fact, the biggest bane of a drug-eluting balloon was in past that the technology could not see the light of the day, which should have been, is basically the the problem was, one was the amount of the drug available would get lost during the navigation. That was the biggest challenge. And in fact, at Blue Medical, the technology we were working is to ensure that can we reduce this loss to a minimal point, which Garima was trying to allude to the point. In fact, sir, our technology is such, like for example, sir, all drug-eluting balloon conventionally are prepared in a way that they are spray coated generally after creating the folds. But we did not take that conventional method of coating. What we did, we took some other difficult method, in the sense we basically, through the pipette method, we actually coated the balloon. It was a very difficult process to do, but still we chose that part. And then what we did, we crimped the balloon, and then we also coated with polyvinyl propylene, which also holds the drug. Now there are three things which we did to ensure that there is no loss during the navigation. It is only when you reach at the site, it that allows the drug to get released. Now, this is what is done in order to ensure that in case of protease, this happens. Now, having said, as a corollary to what Dr. Anil sir said, can we take time? Sir, it is not well studied, but looking into the fact, making 1 + 1 is equal to 2, perhaps could be if you really require it. But one thing is for sure, that you do not have loss of drug while navigating the vessel. That's for sure. That's because of the make, the technology ensures you that. And just because of that, what you get is basically is that you get the advantage of 3 times inflation. It is not very special with us. Just because we get the drug higher level, the concentration achieved is maintained is well to the time, you can always inflate it 3 times, which is not seen with other. We do not know others can do it or not, sir. Hope this answer your question.
Yeah. I think it is the technology that makes it different from the other drug-eluting balloons. That the unique 3I technology, and then the micropipetting process, and then the scaffolding, the way it is functioning makes it that there is no drug loss during transit, and also at three different inflations. Still, at the end of third inflation, it maintains the therapeutic level of the drug concentration, which is higher than that is minimum required to maintain to prevent the near revascularization. That's what is it okay? I think
Absolutely, sir.
yeah,
Absolutely, sir.
yes. Any other questions and comment? I mean, with these newer technologies and evolving indications for drug-eluting balloon, where do you think, what is the future of drug-eluting balloons in applying in different subsets what we have discussed it so far? I mean, one word of comments from all the panelists, and then we'll, if are there any questions in the chat box?
Sir, not in the chat box, sir.
Okay. So, how do you, each one of the speakers, like, how do you place the drug-eluting balloons in the present era of clinical practice of interventional cardiology, and what is the hope, or how do you see the down the line, maybe 5 years or 6 years? Of course, we still need a lot of data. The drug-eluting balloon versus DES in all the subsets. We cannot be too enthusiastic to say that it is going to replace, or definitely to the extent that it is complementary to the drug-eluting stents, especially in the subsets of small vessels and diffuse disease, in restenotic lesions and bifurcations. Especially we know that the diabetics and Indian subset, the vessel sizes are much smaller. At least one third, or around 20 to 30% of the all interventional cardiology angiograms which we see are patients who are taking up for interventions. We do see smaller vessels where we cross our hands, and then what else we can offer for the patients. Even though it is tempting to do DES, definitely we know that for sure they are coming back with restenosis. The restenosis rates are definitely higher even with the third generation drug-eluting stents when compared to the DEB. How the results of DEB are going to really matter, we have to see. We have to wait for some more trials, some more data to accumulate. But it is an encouraging option. We can say that it is definitely a promising option rather than doing a plain POBA or leaving them alone unattended. especially in symptomatic patients, we can definitely offer a DEB with the newer technologies, accepting as a part of the armamentarium for the interventional cardiologists to deal with in the cath lab in the difficult situations. Those are my comments, and then I ask all the panelists to give their opinion on the future of DEB and their present scenario. Thank you. Dr. Anil Sharma.
Sir, basically, already we have discussed that it is already established treatment for small vessels, definitely. ISR, there is no doubt that we are going to treat because it will decrease the metal load also, and it has a good result. Data is coming, and data has come also that it is showing promising results. Now, new technologies like one single balloon you can use at 3 places, so it reduces cost also in our scenario, especially the poor patients. So it is going to be a promising thing in the future, I think. And I'm already using, I have used, and definitely it is a good hardware in our hands to treat patients with. Thank you.
Thank you. Dr. Aravind.
Sir, for me, off late, I'm using it in geriatric populations. Sir, even in ACS patients, I've started using when I find a high bleeding risk, and also in patients with CKD. I'm trying to avoid a stent, and I'm using DCBs. The geriatric patients, it's been very helpful, sir. I'm able to stop the dual antiplatelets in a month, switch back to single antiplatelets. The thought of the bleeding risk substantially goes, sir, especially in people who are 80s. 83, 85, even recently I did for an 88-year-old lady. I was able to comfortably load her. I was not thinking if she's going to have clopidogrel resistance. What if I put a stent? Nothing. Put in DEB, came out, and the patient is doing the 2-month follow-up. She's doing good. But I'm having series of geriatric patients. Maybe at the end of 1 year, when I do the follow-up, I'll be able to answer it more confidently. But telling them upfront, we are avoiding a metal so that we can reduce the antiplatelets, and patients are accepting. So that is one subject I would.
Absolutely, that is one indication. But the only problem with the geriatric patients is the amount of calcium and then the plaque modification. We have to be very sure about that. Otherwise,
Yes.
no, if you just don't prepare properly and with the calcium and all, you try to do DEB, probably it may not really give a very
Unless
promising.
it is going in a provisional strategy, sir. Going in the mindset that I'll prepare the lesions well. If I'm able to stop with a type A or type B dissection, then go do a DCB and come out. And other thing is, sir, we hear the company people saying that the drug is there, but we don't see.
I know there is no marker for no, like
somebody should come with an radio opaque marker of the drug that is there, so that we know if there is drug there.
yeah, some coating or some color.
Some
Yeah,
radio
we agree.
marker.
We always take it granted that the drug has been released.
Yes.
And we have done the procedure adequately. They are all, I mean, like implied that you do the procedure properly, you prepare the lesion properly, and deliver the drug in the prescribed way. Hoping that definitely the CKD patients is one subset, and elderly patients are one where we are really scared of using dual antiplatelets. And then we can safely know that if you accept the result and the result is good, there is no persistent staining or no dissection, no flow limitation, and then good flow, accept reasonably good result, then those are the people who will get maximum benefit with the DEB. I agree with you. Yeah. Dr. Anil Sharma. Anil Sharma, I think we have completed, no?
Yes.
Yeah. Dr. Rupesh Singhal.
Yeah, hi. Thank you. So as I previously pointed out, I think the best idea to conceptualize use DEB is it is in synergy with DES. So we should not see it as an exclusion or an competitor to DES, but as a synergist. So even if we cannot avoid stenting, we can probably minimize the stent length. So that's my take. I think DES and DEB both are going to be here, and both of them, I think we should over a period of time will learn how to use each of them as to improve the patient outcomes for the maximum.
Yeah, that's what in the beginning itself, at the outset, I told that it is not going to be a competitive to DES. It is a complementary one for the DES. Now we have an additional what you call the ornamentarium to the interventional cardiologist, that in places where you cross your hands, you use DEB and then come out with a reasonably good result, hope for the best. So that
Definitely.
is the,
But I
yeah,
think,
yeah.
particularly like though not approved yet for dedicatedly for bifurcation, my use in bifurcation has really brought down my bifurcation PCIs.
Yeah, very true, sir.
Absolutely,
The fun of
absolutely.
bifurcation has gone now.
Yeah. And then no, the beauty of bifurcation is you get immediately good result, you go with happiness, and then no, how long that happiness lasts, we don't know.
No, I mean, I'm
The
yet
more
to
metal,
do
yeah.
check angio for these patients, like, but I have started using at least a DCB, at least for a side branch, for quite some time now. I think probably we need to bring these patients back, do an angio, so that it restores our belief in the therapy.
I think soon we'll get, there are already some trials, and then soon we'll get a lot more data about that is very attractive concept. Do the DEB for the side branch and DS for the main branch looks very attractive and makes sense also.
And we are
Let us
also
hope
looking
for,
at that angiographic pleasure of TIMI3 flow, sir. Seeing
yeah,
with
both the drugs.
dissections, not
Yeah,
seeing that full contrast images, seeing
And
with
it
dissections.
improves the procedural simplicity,
Yeah.
it decreases the cost,
yeah,
no so many multiple wires, balloons, you save a lot on cost as well.
yeah. And improves the longevity of the cardiologist also.
Yeah, true.
The stress that is going with the biceps, I mean bifurcation and all, no, that is gone. Yeah. Anybody left over? I think one more speaker. I think we have covered everybody.
Yes, I believe so. If you can just allow us 5 minutes, as answer
Yeah,
would just like
please,
to.
Sir,
please,
I wanted
please go
you
ahead.
all to, sir, go with one thought which I keep on talking to each intervention cardiologist. Sir, this I am talking as a capacity of being basically a student of pharmacology, not as a doctor. I don't qualify you to become a student of yours, because I always believed and premise is a student of a doctor is also a doctor, and I am not anyone of that. But just because I had been a student of pharmacy, I always keep on juggling with understanding of pharmacology and all this. So actually, one thing which keeps on coming to the sometime at different circles, that basically paclitaxel based drugs are known to cause aneurysms, which sometimes becomes a kind of a misconception and a barrier about this drug. In fact, aneurysm is about 0.3 to 3.8% is seen with any sort of PCI, as per any data I can share with you from Euro Intervention 1 data. But at the same time, sometimes we also need to understand what is that sometimes this aneurysm happens because, and you also have to slightly, I wanted to throw some light on the difference of action, the way paclitaxel and sirolimus or some other drugs do acts. Here the paclitaxel, the way of sometimes it may cause aneurysm is also because of the fact that the process of paclitaxel is a process of apoptosis and not necrosis. And there is a slight difference between the necrosis and apoptosis. You being such a learned person, you know, sir, the definition here, apoptosis is more of a programmed cell death, and whereas necrosis is an uncontrolled injury which happens with many other drugs, which may lead to membrane rupture, whereas with apoptosis, it's more of a shrinkage or a DNA fragmentations, not leading to inflammation in case of apoptosis. With necrosis, of course, and this can be easily measured with the content of LDH, that is lactate dehydrogenase, which is seen minimal with apoptosis. So therefore, targeting smooth muscle cells is good.
What happened? We lost your voice. We are not able to hear you, Reza.
So am I audible?
Yeah, please.
Yeah.
I think we lost him. There is some technical problem there.
Yeah, yes, sir.
Yeah.
No problem, sir. I would just like to thank you all for, taking your time out. And I believe it would take some more time otherwise. So we'll be connecting it again, sir, maybe, and in some other time.
Yeah.
So
I think it's a wonderful session on regulating balloon, and
Yes,
then a lot
yes.
of learning points, exchange of views, and I really enjoyed the session. Thank you, Translumina, for organizing a very
Yeah.
nice.
So, sir, today we had all our expertise from North, East, South, and West. So
Yeah.
it had been a very wonderful time.
Across India, and then thank you all. We have done a wonderful job, all the speakers.
Yeah.
So have a nice time, and then good night all.
Thank you.
Thank you very
Thank you
much.
so
Thank
much, sir.
you.
Thank you.
Thank you.
Thank you.